think it's much different from yours. Mostly they are not diagnosed antenatally and they come very late, mismanipulated, etc. So probably most, if not all, our patients run in the high risk category and not the, the low or mid risk category. And this poses a lot of logistic even problems in dealing with the kids. Anyway, thank you very much for this.
If I were to pick the 4 reasons why survival has increased over the last 20 years, I would say first, better prenatal diagnosis. Second, better way of ventilate these infants. Third, better hemodynamic diagnosis and control. And 4, delay surgical repair. Those are the 4 elements that have basically shown to improve outcome over the last 25 years.
We can complete the program?
Yeah.
Go ahead.
So I'll be very brief. Now, when we talk about the post-operative management, it's not much different than prenatal. Okay, the principles are the same. You still need to use gentle ventilation, proper use of fluid management, proper hemodynamic control, TN echo, use the proper inotropes if needed. So things were not going to change just because the defect is closed. So the same principles that we discussed before surgery are going to apply after the surgery. So ventilation, oxygenation, and air pressures, the same. So acid-base status, the same. Try to maintain normal pHs, about 7.25. Hemodynamics, keep doing TN echoes and see where the problem is and what, if you need inotrope, what type of inotrope you need according to the findings on the TN echo. Analgesia, definitely these babies need analgesia after the surgery. And usually they require higher doses of morphine and fentanyl than what they were requiring before the surgery. But that higher requirement for narcotic usually shouldn't be more than 48 hours, 72 hours max after surgery. And then you should be able to start weaning those inotropes. Again, there is no reason to paralyze these babies after surgery, same as prenatally. A proper handover between the NICU, anesthesia, and the surgical team is crucial. You need to know exactly what happened during the OR. You need to know how much fluid this baby got, what happened to the blood pressure, what happened to the blood gases, if they change the ventilatory management, if they change the pressure, you need to be aware of all that. That's crucial. So proper handover is extremely important. You also need to do a chest x-ray right after surgery, okay? There are reasons for that. First of all, during surgery, during transport, the ATT may be malplaced. So you need to be sure the AT tube is in the right position. You need to be sure that your central line hasn't been displaced. You need to be sure that the NG tube is in the right place. If the surgeon put a chest tube, and we can discuss the indication for chest tube or not, you need to know that that chest tube is in the right place. Central line position, NG position, and also, more importantly, you need to know how good the lungs are expanded after the surgery. So there are some expected chest x-ray findings that are normal findings after surgery, okay? And these findings change chronologically as the baby gets extra hours after surgery. The first one is, this is normal. You do a chest x-ray after surgery and you should see air fill on that side of the chest. This is physiologic, okay? This is not a pneumothorax. The lung, the bowel that was there is going to be replaced by something. It's either fluid or air, okay? So at the beginning, it's usually air. That lung on that side remains collapsed. The bowel is not there anymore. So that empty space needs to be filled now is usually air. Most of these babies do not need chest tubes, okay? I think we can discuss that later. It's up to the surgeon to decide if you're going to keep the chest tube or not. Again, this air is not under tension. So this amount of air does not cause usually any hemodynamic problems. So in theory, babies should not need a chest tube after surgery. Another finding is after 24, 36 hours, this air is going to be slowly replaced by fluid. The air is going to be reabsorbed. So that space needs to be filled by something, and that's usually fluid, okay? Especially as the lung on that side starts expanding, whatever expansion you can get, that mediastinal shift is going to move towards the middle and achieve a normal position, okay? So it's normal to see some fluid on that side of the chest, okay? Now, there are some conditions that will complicate surgery. These are not normal. One of them is chylothorax. When you see that side of the chest filled with fluid, but the fluid now does not reabsorb and is causing mediastinal shift again, you need to be suspecting chylothorax. That's because sometimes during the surgery you can damage the lymphatic drainage on that side of the chest, and that can cause usually unilateral chylothorax. So you need to be aware of that because these babies usually need a chest tube to drain that fluid out. Abdominal compartment syndrome is another complication that sometimes surgeons have to deal with. Sometimes you can damage the bowel when you try to put the bowel back into the abdomen. And these babies usually develop abdominal distension, develop persistent metabolic acidosis, decreased urine output, change in color in the abdomen, and you need to suspect that there is an abdominal compartment syndrome. Sometimes they need to go back, reopen the abdomen, and keep the abdomen open. Okay? An infection is another complication that can happen right after surgery or much later on, especially if they have a patch. That patch can get an abscess and can get infected. So you need to be aware of that. And hernia recurrence is also rare, but it could happen. Most of the cases of hernia recurrence occur later on, even after the baby has been discharged. In many cases, it's asymptomatic, or it could present with acute respiratory failure or a bowel obstruction. So you need to be aware of that, and sometimes you need to do a serial X-ray to be able to diagnose this, especially if it's asymptomatic. This is an X-ray showing hernia recurrence. So, in general, again, oral nasogastric tube for continuous suction right after surgery. Kid baby NPO, usually no more than 48, 72 hours. Most of the babies will recover some degree of peristalsis after 48, 72 hours, especially if you're able to decrease the narcotics. And you can start either giving MEF or minimal enteral feeding and start at least suspending or decreasing the suction that you are doing. Continue with the same management of fluid and initiation of TPN. Remember, these babies are at risk for third spacing, so be careful with the amount of fluid. Always do accurate in and outs and try and maintain a strict fluid balance. And these babies need nutrition, so you need to provide as much as nutrition as possible through TPN. Antibiotics, usually the surgeons decide that. Usually they recommend 24 hours of unsafe broad-spectrum antibiotics when there's no patch. And when there's a patch, usually they like to use 3 days or 7 days, depending who the surgeon is. Okay? In terms of ventilation, same as we discussed before the surgery. The difference is that these babies will sometimes need slightly higher mid-airway pressure after the surgery. That's because during the surgery you tend to collapse more the lung on that side, and usually you collapse the lung on the other side. So immediately after surgery you may need to use a higher mid-airway pressure that you were using before, but that should be transient. As soon as you re-expand the lungs, you should start going back to your initial settings before the surgery. Okay? Again, aim for a PAP or less than 25, gentle ventilation. Usually use preductal SATs, 90 to 95. Permissive hypercapnia, same as prenatally. Don't aim for a CO2 of 40. Some of these babies need CO2 in the 50s, sometimes low 60s. Okay? As I said before, guide your mineral pressure on your pulmonary graphics, your chest X-ray, your blood gases, your FiO2 requirements, and your lung ultrasound if you have some. Okay? And wean ventilator as appropriate. When the defect is closed and the bowel is returned to the abdominal cavity, most of these babies, of course, depends on the severity of lung hypoplasia that you had before, should be able to be at least try extubation after 2 or 3 days if the cases were mild to moderate. Okay? So don't assume this baby will need to be intubated for 2 or 3 weeks, because most of these babies, when the pulmonary hypertension has resolved, has diminished, and the lungs are re-expanded, most of these babies could be handled without a tube in place, either CPAP or NIPPV. So, sedation, again, maintain spontaneous respiration. Same as we say before, we say after surgery. Now, as I said, many of these babies will need a bit more morphine and fentanyl because of the pain, but that shouldn't last more than another 2 or 3 days. And then you should start weaning those narcotics as quick as you can do it, especially if you're going to extubate. We should consider IV Tylenol because that will help you minimize the amount of narcotics that you're going to use. Again, start weaning narcotics after 48 hours. We use a new medication, dexmedetomidine, which is similar to the clonidine, but it's an IV preparation that is a selective alpha-2 agonist and may help you to bridge between narcotics and non-narcotics. So we find that this medication is very useful, and you can actually decrease the amount of narcotics when you start using dex in these babies. Usually the initial dose is 0.05 micrograms per kilo per hour, and you should titrate accordingly. And again, same as we said before, minimal handling. Do not irritate these babies too much. Now, complications that are associated with diaphragmatic hernia, gastroesophageal reflex is present almost in every single baby. I would say in 85–90% of the babies will have some degree of GE reflux. Okay, and this is due to different reasons. You can have esophageal dysmotility, you can have shortening of the esophagus, you can have dilatation of the terminal part of the esophagus. It may be due to increased post-op intra-abdominal pressure when you return the bowel into the abdomen. You can have also an abnormal diaphragmatic motion that usually helps to close the lower sphincter. So all this could predispose to GE reflux. Bowel obstruction is another complication that we mentioned before. That's usually related to either a damage of the bowel during the surgery, or it could be due to adhesions that will happen later on. And you need to be aware of that, and you need to be knowledge of that. Also, we know that babies that with diaphragmatic hernia will have some degree of malrotation. So, although the risk of volvulus is low in babies with diaphragmatic hernia, some surgeons will do a prophylactic GLAD procedure when they return the bowel to the abdomen. But you need to be aware that these babies are relatively higher risk for volvulus. Malrotation. And pyloric stenosis, although rare, has been seen in about 2 to 5% of the babies with diaphragmatic hernia. So if a baby starts having all of a sudden projectile emesis, think about pyloric stenosis. The degree of hypoplasia of the lungs will determine not only the survival rate, but the long-term morbidity of these babies. So if these babies are going to be oxygen dependent or ventilator dependent for a long time, it will depend mostly in the degree of pulmonary hypoplasia and the degree of acute lung injury that you have imposed with your ventilator. So that's why it's important to minimize lung injury. Chronic lung disease is a condition that, again, will develop usually because of excess exposure to oxygen and pressure from the mechanical ventilator. Pulmonary hypertension is, as we said before, there's two components, the fixed component and the component that you can change with medications. Many of these babies may resolve the pulmonary hypertension during the hospital stay, but especially if they develop chronic lung disease, may develop later pulmonary hypertension with eventual right ventricular failure later on in life. So these babies need to be followed very closely with TN echoes done every few weeks or every few months, just to be sure that the pressures do not start going up, going in the wrong direction. Many of these babies will develop like an asthmatic type of condition due to increased airway resistance or increased bronchoreactivity. Many of these babies will need some bronchodilators. And again, because of the risk of hypertension and pulmonary hypoplasia, these babies are at risk for hypoxic respiratory failure because of the two conditions. Many of these babies are also at risk for neurological sequelas. Especially those babies that have severe cases of congenital diaphragmatic hernia, those babies that have suffered significant hypoxia, significant acidosis, those are the babies that most likely are going to experience either ventriculomegaly, white matter injury, or enlarged extraaxial spaces because of brain atrophy. Babies that are higher risk for developing long-term brain abnormalities, especially babies that had right diaphragmatic hernia with liver herniation. Those are the cases that usually end up with more brain injury. And babies that require ECMO are also at risk for infarction and intracranial bleed. So, seizure is another complication, long-term, that many of these babies could experience. Chest wall deformities is something that most of these babies with diaphragmatic hernia will experience. That's because of the inequality of the chest, the right and the left, because of the diaphragmatic hernia, and the surgery that usually is imposed in these babies. So they could end up with Pediatrics buttons, the chest wall hypoplasia, or scoliosis, which is also quite common in these babies, and many of these babies will require surgical repair of the scoliosis when they get to later on in life. So things that you need to do before discharge in terms of follow-up preparation to follow these babies is be sure you follow the weight, the length, the hair circumference to be sure these babies are properly growing. Chest x-ray, just to be sure there is no recurrence of the hernia. Immunizations, echocardiogram as a baseline and follow-up for pulmonary hypertension. Brain MRI, many of these babies will require brain MRI looking for those complications that I mentioned before. Hearing evaluation, these babies are at risk for hearing losses. We know that hearing impairment has been associated with hyperventilation and low CO2s. So if you can prevent hyperventilation and low CO2s, most of these babies will not experience hearing losses. But that's something that needs to be checked. And a normal neurodevelopmental evaluation before they go home and assessment of oral feeding. After discharge, routine evaluation every 3 months, pediatric surgery evaluation every 3 months, chest x-ray every 3 months, especially if the baby had a patch, the patch is present because of the risk of recurrence of the hernia. RSV prophylaxis, these babies are at risk for develop significant respiratory insufficiency when they are exposed to RSV virus, so it's recommended to get immunization for at least the first 2 years of life. And as I said before, just to follow and prevent or diagnose early pulmonary hypertension, do an echo every 3 months, especially if they are going home on oxygen. It's also recommended to do pulmonary function tests every 6 to 12 months, hearing evaluation every 3 months, developmental assessment every 3 months, and again, when they get to be teenagers, they usually need to be screened for scoliosis and chest wall deformities, usually annually until they finish growing up. Thank you very much.
Thank you, Dr. Ruben, for this comprehensive, informative lecture. And now open the discussion. We have only one question. Does late diagnosis of CDH hours after delivery affect the severity of CDH? Most of cases in Egypt presents after delivery, immediately.
Oh, that's your experience here in Egypt? Most cases are diagnosed postnatal?
Postnatal.
Yeah, as I said, if you were to improve survival and decrease the risk of long-term morbidities, you need to be well prepared. Every time you make diagnosis later, after delivery, then of course your outcome is not going to be as good. But the management should be the same. You're going to have more complications because you're not ready, but the management should not change just because you made diagnosis later. So always use the same principles that we discussed here in the presentation.
Thank you. Any questions?
I want to ask about your center experience in fetoscopy for fetal surgery for cases by tracheal occlusion.
Yeah, I mean, that's a $1 million question. As you know, there's a lot of research going on in trying to prevent significant hypoplasia by occluding the trachea in utero. The way that works is because you don't allow the lung fluid production to escape the lungs, so you keep the lung fluid inside the lungs, and that promotes alveolar growth. So far, the studies have not shown to improve outcomes significantly, so it's not considered standard of care. But I would say that in cases of severe congenital diaphragmatic hernia with poor prognosis, those cases should be maybe considered for antenatal intervention.
Yeah, just I would like to add, in our center, I'm a member of the group. There is a multidisciplinary group, including the neurosurgeon, surgeon, to consider 2 indications for the future interventions in intrauterine. Congenital phragmatic hernia is one of them, and congenital meningocele. So both these indications actually, like there's some centers, few centers in USA, we consider fetal interventions. Now it is present in Toronto, and it is case by case. It's not really like a general practice. It is based on certain criteria for severity, and upon approval, acceptance from the family after understanding the concept and the risk of this technique. In our center, we're just preparing for almost 2 years now the protocols, and we may join Toronto for this experience, but there is no, like, we haven't started yet.
Thanks.
Coming to the end, thank you very much.
Just one question. We have 2 questions. Or you start first. Just a practical question, Robin. You said you choose volume guarantee 4 mL per kilo. What if the working PEEP that needs to deliver this pressure, this volume, is above 25, like 30 or so? Do you switch immediately to high frequency, or you just give time?
No, yeah, so it depends. If it's the first gas, I may wait. See, sometimes you need to be sure that your lungs are open, because it's not just the volume and the PIP, it's also the PEEP. If your lungs are underinflated, you may get PIPs that are too high. But if you realize that it's maybe your PEEP the problem and you increase the PEEP, you may improve the compliance. And with the same volume, an hour later with a better PEEP, you may get PIPs lower than 25. So no, not necessarily you need to rush to high frequency as soon as you get a PIP of 25. But that you should be aware of that limit if it's persistent.
My question also about the volume guarantee. You cited that you are using a volume guarantee of 4 milliliter per kg. This number has been actually advocated by the study of Martin Kessler, but their study, it was retrospective study actually, and a small number of babies, and they have been using this number to have CO2 of 40s. So I think maybe if we are allowing a higher CO2, the number of 4 maybe slightly higher than required.
As I said, this is just an initial number,
Okay.
and you can take the number or leave it. You have to start somewhere. But the number is not the most important thing, is what, as you said, what CO2 you're getting with that number and what type of expansion you get. There are some babies that are going to be with 3.5 per kilo. So you always have to use the lowest volume that will give you a reasonable CO2. If it's 3.5, great. If it's 3, even greater. As I said, most babies will need around 4. Some babies will need more than 4. Okay? As long as your PIP is less than 25, you can keep pushing that volume up as long as your pressures are low. So, as I said, it's not just the actual number, it's other parameters that you need to look for. CO2 levels, PIP levels, and so on.
Actually, we do it the other way around. We use the pressure and we monitor the volume, and if we are having a good CO2 on whatever number of tidal volume, we accept it. We don't use volume guarantee in these cases.
So you use pressure.
Pressure, yes, not volume.
Yeah, the problem with that is that, remember, the compliance of this lung will change significantly in the first hour, significantly. So you may have to do 2 frequent blood gases to be sure that you're not over-distending this lung. That's why I think volume is safer. I'd rather go the other way around, because again, if this was a static problem, I have no problem with that, because your limit is 25, it's not the volume. But because this lung will change so much in the first hour, I'd rather be safer and use a specific volume and see what kind of pressures I get, and then adjust my volume according to the CO2 and the pressure they achieve. But
the last point of my question regarding the hyperinflation in these lungs, actually, doctor, yes, أنا عندي بكتب. Actually, Dr. Yasser said something about recruiting these lungs, and you are saying about using a higher PEEP to improve compliance. But actually, the physiology of the diaphragmatic hernia, the lung is not atelectatic, it is not recruitable, it is hypoplastic. Usually, you are giving this pressure to the contralateral side, which is most of the time not stiff at all.
Oh, okay, I'll
So I
I
think
agree to disagree,
I
because
think-
I think the main issue that we have, especially after delivery, is that the good lung is usually not well expanded. Because you have significant mediastinal shift for whatever reason, most of the time your good lung is not fully recruited. And that's why sometimes you get problems. I'm not talking about trying to re-expand or recruit the bad lung, because there's a limit you can do with that. It's usually the good lung that you need to be sure that it's fully expanded. Okay? I think Yasser showed an X-ray in which you can see in two different X-rays. In the first X, the right lung was fully expanded, and the baby was in PEEP of 7 and requiring 70% oxygen. As soon as you use higher PEEP, the PEEP will go to the good lung and will expand that lung, and then the FO2 will come down, and you will see a much better expansion. So.
But there is some evidence that higher PEEP will cause lower compliance, especially, actually it was especially post-operatively, actually.
Right, but yeah, no, I
to
agree.
be
I mean,
honest.
you can go the other way with the PEEP. If you give too much PEEP, you can over-distend the lung for sure. Yeah, that's why you always have to use your lung mechanics and your flow waveforms to be sure that you're not overexpanding the lungs with your PEEP. I agree. If you push the PEEP too much, your compliance will worsen.
The study I am referring to was comparing 5 to 3, actually, post-operatively.
In respect to that, it is the same concept of lung recruitment, but it's different strategy. So in other patients, for example, chronic lung disease, we may expect the PEEP to be as high as 14, 15, 17. But as I showed in our cases, we started with low PEEP, like 7, increased to 8 and 9. The best parameter to show that you're in the right direction, regardless what is in the literature, there's a lot of things that does not really reflect the real physiology in the literature. So not everything in the literature is good. Once you increase the PEEP by 1 or 2 and you see there's improvement in the oxygenation, they cannot assume that less FiO2 will be associated with hyperinflation. It's opposite. So you keep increasing and there's no improvement, you see worsening, so you are in the wrong direction. So it is based on you recruit the lung in a way that you see the improvement, then you are in the right direction. And again, the list of the parameters that you are following, they are very good evidence-based markers to show you that your oxygenation is getting better or not. All of the very easy to calculate scores or markers that I showed during the presentation, OI, oxygen saturation index, AA gradient, whatever, everything is improving, and means that you are in the right direction. And again, you should be very cautious. Just not in the same as we do in other cases, increase PEEP. You can jump maybe 5 or 6 or 7 in few steps up to open the lung. No, it is just 1 and wait and see, and if there is not enough, you can increase by another 1. So it was from 7, 9, one of the severe cases was maximum 11, which was typically high, but the infant improved.
And one more thing, every time you change the PEEP, if you did the right move with the PEEP and the compliance is better with a higher PEEP, you should be able to see a lower PIP using the same volume. So if you increase the PEEP and all of a sudden your PIP pressure goes up, it's because definitely you make the compliance worse if you're using volume guarantee. So your PIP should actually lower if you are improving the compliance by increasing your PEEP. And that's another parameter that you should follow. What happened to the PIP after you make a change on the PEEP?
Thank you. Thank you, Professor Ruben. Thank you, Dr. Yasser. في more question? دكتورة أميمة دكتورة أميمة هتتكلمنا دلوقتي على tale of two cities, diaphragmatic hernia over decades.